Good morning, everyone. And I think shortly we'll start the next session, that is orbital pathologies demystified. And I request, I'm Dr. Ruchi Goel. I was heading the ocular oncology and plastic unit at Maulana Azad Medical College. With me, my co-chairpersons are Dr. Shalu Bageja, Vice Chairman, ophthalmic department at Gangaram Hospital, Dr. Seema Das, head of the ocular oncology and oculoplastic at Shroff Eye Center, and Dr. Shaleen Shah, a youngest co-instructor, director of SNE Eye Center at Baroda. So I would request all my co-instructors to please join me on the dais. And Dr. Seema, would you first put up your presentation? Are you ready with that? So, yeah. So I would. क्या करें जाए? I think we'll have to start. That's all. So I would now request Dr. Seema Das to first present. She'll be speaking on orbital infections. Inflammations, how? Can somebody please give me the program of this event? So, Dr. Seema, please start.
And thank you for. No, it's on. Yeah, it's on, right? Yeah. Thanks for this opportunity, and sorry for this little change in the sequence. I know we are supposed to start with the basic evaluation and the sort of the anatomy part of it, but because I have another commitment, so I will be speaking about orbital inflammation. So inflammatory diseases are something which all of us see, be it oculoplastic surgeon or a general comprehensive ophthalmologist who does cataract also. So we cannot avoid seeing inflammation. And we all know the cardinal signs of inflammation: heat, like increased temperature, redness, swelling, pain, loss of function. These are all the cardinal signs which we have been taught in the pathology books. Now, if you see a couple of cases, this was a young gentleman, 30-year-old, presented with this proptosis, sudden onset, lot of pain, redness, chemosis. All the signs of inflammations are there. Movements are restricted. His vision is also affected. So it's a hot, red, painful orbit with lot of swelling, and function is affected. But what we see on the imaging is a mass lesion which is sitting there in the orbit. So this also presented as an orbital inflammation. He did not respond to the conventional treatment which was given to him, that is steroid, and eventually when we did the biopsy, we know the diagnosis. This was a fungal orbital cellulitis which presented as an orbital inflammation. So these are specific inflammation. Again, another lady presented with this painful red eye, proptosis, loss of function, movement restriction, and mass in the inferior orbit. Biopsy showed liquefactive necrosis with areas of caseous necrosis. She eventually developed areas of limbal thinning, corneal thinning. So this was basically a autoimmune disease with lot of inflammation with necrosis which was happening, and her Cianca was raised. Biopsy showed evidence of necrotizing inflammation, vasculitis, small vessel vasculitis, and we know the diagnosis. This is Wegener's. So inflammation like this are the inflammation with specific causes, like either it could be an infective etiology also, which can present with inflammation, that is fungal infection, foreign body granuloma. And then there is a category of idiopathic inflammation with specific histopathology, like we saw in the second patient, like in Wegener's, where the presentation is like any other inflammation, but the histopath is very specific, which gives the diagnosis. And then we have the basket. If these two are ruled out, then the whatever rest inflammation is there goes into the basket of non-specific idiopathic inflammation. So we have to understand that NSOID, non-specific inflammation, is a diagnosis of exclusion. We can't just diagnose or label the patient as NSOID on the first visit based on the signs of inflammation unless we work up the patient to rule out the other specific causes. So NSYD that's the biggest chunk, so I'll be focusing more on that. That's not a single disease entity. It could be like, disease which is involving every orbital tissue, but the unifying feature here is in a typical case is the abrupt onset of inflammation with a lot of pain, extreme sensitivity to the steroid. They respond to steroid. Imaging is usually very non-specific, showing irregular margins of the tissue, whichever tissue is affected, with a lot of signs of edema within the orbit. But we have to remember that atypical presentations are also possible. So according to the anatomical structures which are present in the orbit, the patterns of presentation could be based on which structure is affected. If the muscles are affected, it becomes a myositis, lacrimal gland dacryoadenitis, anterior inflammation, diffuse inflammation. If the orbital apex is affected, apical, and if that lesion is or the inflammation is predominantly around the optic nerve, it's a perineuritic. And the last variant, which is a very, again, more specific variant, is a sclerosing variant. This young girl comes with history of, her main complaint was double vision. She has some redness. If you see, there is some congestion of the conjunctiva in the right eye, but what is more striking is the movement restriction. So function is affected, there is some pain, there is redness, but it's not a hot red swollen orbit. So she doesn't fit into the signs of specific orbital inflammation. So do we still label it as inflammation? So idea here is to highlight that not all inflammations are acute. There can be subacute presentation. This girl had a myositis. We can see the muscle which is thickened, which is irregular edges. So myositis sometimes can present without any signs of overt inflammation, and they do respond to steroid. That is one of the diagnostic indicator again if you don't want to do a biopsy. So we can see after steroid the movement has become better. So it indirectly kind of confirms the diagnosis that it indeed is a myositis. Myositis can be acute or subacute in presentation, could involve one muscles or multiple, can be atypical also, but the unifying feature are the irregular enlargement of the muscle which does not spare the tendon, unlike in thyroid eye disease where usually it's a tendon involvement. This was a gentleman with bilateral multiple muscle involvement. Again, young gentleman, signs of inflammation, everything else is there. What we see is a muscle thickening. But what is striking here is probably the tendon which is spared in this case. So we need to differentiate the cases of idiopathic orbital inflammation from the acute stage of thyroid orbitopathy, where the overlapping features can be there both on imaging as well as clinically. Cystosarcosis, very common in our setting, can present like a myositis kind of picture. B-scan or imaging usually gives the diagnosis, and sometimes there can be infiltrative pathology within the muscle, like this gentleman had extraocular muscle lymphoma which presented with signs of inflammation. So we have to be aware of what are the cases where we need biopsy, and we'll be talking about it later. So generally if it's an unilateral typical myositis, which is a single muscle disease, they're usually good prognosis. So conservative treatment with either NSAID or low dose steroid is sufficient. But if it's an atypical presentation, multiple muscle involvement or recurrent course of disease, we need to rule out any systemic cause, and more often than not they will need high dose steroid and sometimes biopsy if it's a recurrent inflammation. Moving on to the next pattern, young lady presented with a typical red hot painful orbit, swelling, function affected, there is ptosis, so that's the function which is affected, and she has an S-shaped lateral drooping of the eyelid, which is almost characteristic of an dacryoadenitis, acute dacryoadenitis. So prominent, it can involve the orbital lobe or the palpebral lobe. From pouting lacrimal drugs can be visible, and there is a localized congestion and chemosis at the site of the lacrimal gland. So generally, how do we treat dacryoadenitis? We go by the function of the gland, and the gland's function is measured by the Schirmer's. If the Schirmer's is affected, that means the gland, lower the Schirmer's is, more is the gland affected. So more intensive is going to be your treatment. So anything less than 5, we generally go for IVMP. If the Schirmer's are somewhere between 5 to 15, oral steroid might be sufficient. If the Schirmer's is preserved and more than 15, even non-steroidal anti-inflammatory might work. This was another lady, subacute presentation, presented like a dacryoadenitis based on the imaging finding, but since this was an atypical presentation, did not respond to steroid, we went ahead with biopsy, and what turned out to be was an IgG4 inflammation. This is a relatively new entity which we should be aware of, especially the atypical presentation of dacryoadenitis, which is one of the commonest presentation of IgG4 disease, and there are specific criteria to diagnose it. So if on the histopath, if the ratio of IgG4 positive plasma cells versus IgG is more than 40%, or if the serum IgG4 level is raised, then the diagnosis becomes an IgG4 related inflammation. There are very specific criteria and guidelines which are given for the diagnosis. Steroid remains again the mainstay of treatment, and many of them will need immunosuppressants also because these are chronic disease, and sometimes surgical debulking also. Rarely can be bilateral recurrent, but this was a little unusual because this gentleman had bilateral dacroadenitis, but the Schommer's was preserved, which is atypical of a dacroadenitis, idiopathic dacroadenitis. So we went ahead with the biopsy, and what we found was caseating necrosis, and AFB was positive. So this was a tuberculosis infection which presented like a dacroadenitis. So there are a list of differential diagnoses of dacroadenitis: viral, bacterial, autoimmune diseases, sarcoid tuberculosis, even infiltrative disease like leukemia, lymphoma, which again we should be aware of. And this needs to be ruled out by a biopsy before we label the patient as an idiopathic dacroadenitis if the presentation is atypical. This is the pattern 3, diffuse NSYD. There is a diffuse inflammation of the orbit, but again this can mimic many other pathology. All of this looks like a diffuse NSYD, but the first patient had a caroticocavernous fistula with a corkscrew dilated blood vessels, and we can see the dilated superior ophthalmic vein on imaging. So this is not a non-specific diffuse orbital inflammation. This is a specific cause and needs a specific treatment. Steroids are not going to help cure the disease. Second one was a mass lesion, rhabdomyosarcoma, presented like an orbital inflammation. The third was a venolymphatic malformation with some acute bleed probably, which presented like an orbital inflammation. So these are all the differential diagnoses of NSYD, and which we need to be aware of. Moving on to the next pattern, that is orbital apex involvement. That the apical NSYD usually presents like an orbital apex syndrome, and depending on the involvement of the nerve, there can be total ophthalmoplegia, the vision can be affected. There can be mild proptosis, chemosis, depends on the severity of the inflammation. Host of differential diagnoses, including Tolosa-Hahn syndrome and tuberculosis, Wegener's, all of this can present. This is one entity which is difficult to diagnose on histopath because that's an area of the orbit which we can't diagnose. So we can do a systemic workup if there is a suspicion and give a trial of steroid. If it responds very quickly and a good response, then sometimes that corroborates your diagnosis. The next pattern is the perineuritic, where the inflammation is predominantly limited around the optic nerve, like in young girl, where we can see a lot of inflammation around the sclera and around the optic nerve. So this is a perineuritic pattern of orbital inflammation. Again, after ruling out any other systemic cause like tuberculosis or other granulomatous or autoimmune disease, steroid remains the treatment of choice. Coming on to this gentleman, he has red, painful, swollen orbit, increased temperature, all the signs of inflammations are there, but if you see his imaging, there seems to be a mass lesion with a lot of destruction of the bone, which is again not fitting into the criteria of imaging of orbital inflammation. We hardly see bony changes in idiopathic orbital inflammation. So do we still label it as inflammation? Definitely not a typical inflammation, maybe an atypical inflammation, but this definitely needs a biopsy to rule out other causes. So we did a biopsy, and what we found was the sclerosing, lot of sclerosis with a lot of desmoplastic reaction, dense fibrosis, and very paucicellular infiltrate. All of these are diagnosis of points towards the diagnosis of a sclerosing variant of NSYD. And this is one variant where there can be a lot of bony destruction, and it can mimic a, the tumor or neoplastic etiology. Other DD of this condition could be fungal, sarcoid, Wegener's. There can be bony changes in these entities also, and other metastatic cancer also needs to be ruled out. Again, the treatment remains steroids. Just quickly going into the algorithm, I'll just finish here. If there are typical features, if it's a first episode of inflammation, it's a unilateral disease, there is no systemic evidence of any other cause for the inflammation, we treat this patient with either non-steroidal or low-dose steroid, depending on the severity of the inflammation. Recurrence is very unlikely in a typical case. If it responds, then it's fine, we don't have to do anything else. But if it's a bilateral disease, there is a recurrent disease, or it's an atypical pattern of inflammation like what we saw, or it's a perineuritic inflammation where the optic nerve or the visual function is affected, high-dose steroid is the treatment of choice. So IVMP is the treatment of choice. Many of them will need immunosuppressants depending again on the severity of the inflammation. We need to investigate for systemic disease, keep the patient on a close follow-up, and if it's coming back, typically more than 2 or 3 recurrences per year is an indication for going for biopsy. And if on biopsy we find a specific cause like Wegener's or sarcoidosis or any other cause, we then treat the specific cause for the inflammation. So I think I'll stop here, and thank you very much.
Thank you, Dr. Seema, for an extensive talk. Just one question, just for the benefit of the audience. One is, if you have to take a biopsy, which lobe you should target? And the second is, like many of these patients, as we know, they keep coming back again and again, very dissatisfied that,
Yeah.
So what should be told to the patients, what kind of counseling should be done before you discharge them?
Yeah. So generally, if our diagnosis is orbital inflammation after all the workup and everything, we tell the patient this is one disease where there is a chance of recurrence. So they need to be prepared that, we are treating it. It's not that it will give a complete cure. There are possibilities the disease might come back. And we also tell them on the first go itself, right now we are not doing any biopsy. We are giving you a trial of treatment, response fine. If there is no response, we will go ahead with a biopsy. So they are mentally prepared that, this is part of the treatment which is already planned and not a treatment failure. Sometimes they label it as a treatment failure. Second thing about the biopsy site. So biopsy should be done from, generally if it's a lacrimal gland inflammation, we go by the imaging finding and clinical evidence of which lobe of the gland seems to be more involved. So if it's predominantly the orbital lobe, we biopsy that. If it's predominantly the palpebral lobe, we biopsy both. We usually avoid biopsying the palpebral lobe because that is the lobe which is the, the functional lobe, and damaging the kind of, the ductules can actually end up the patient getting a lot of dry eye. So generally, as much as possible, we avoid biopsying the palpebral lobe, and more often than not, it will be the orbital lobe which will be involved, which will need biopsy. These are the atypical cases. Generally, the palpebral lobe involvement are in the typical dichroadenitis who usually responds well to steroid.
Yeah, Dr. Seema, so when the patient has the recurrence and is already on steroids, so you have to discontinue steroids.
Yes.
For how long period you take a gap?
Preferably 6 weeks.
Because the symptoms will be increasing in
Correct.
those periods.
Yeah. So preferably 6 weeks if the symptoms are not so severe and the patient can tolerate it. But if not possible, then at least for 2 weeks. So we discontinue the steroid before we go for biopsy. Otherwise, we might miss the findings. The findings can be masked because of the steroid.
So thank you so much, Dr. Seema. I would now invite Dr. Shalu. She will be now building up actually how to examine a case of proptosis, what all things to be kept in mind, and then we'll go to the next talk of how to manage those tumors.
Thank you, Dr. Ruchi, for including me in your course. It's not showing there. So orbital disorders, as we have already seen in Dr. Seema's talk, they are quite challenging in diagnosing, and so thus a proper systematic and thorough comprehensive evaluation is needed. So before we start the evaluation, this is not moving, excuse me, not moving. So proptosis is defined as the abnormal protrusion of an eyeball beyond the boundaries of an orbit. It can be following an isolated orbital pathology, or it can be extension from the adjacent structures, or like sinus or cranial cavity, or maybe a manifestation of a systemic disease. Exophthalmos, which was earlier synonymous to proptosis, was now reserved for prominence of eyeballs secondary to thyroid eye disease. So any forward bulging beyond 21 millimeter or measurement of more than 21 millimeter or asymmetry of 2 millimeter is considered as proptosis. Some of the other terminologies which one should be aware of is dystopia, which is the displacement of eyeball in coronal plane due to the extracorneal mass. And exorbitism is used when there is a shallow orbit or reduced orbital cavity. And pseudoproptosis, it mimics proptosis. There is no forward bulging, and it's seen in the conditions like ophthalmos, high myope, retraction of the lid, and the contralateral in ophthalmos. So coming to clinical evaluation, it requires a thorough meticulous history taking and systemic and ophthalmic examination, so that we can narrow down our differentials and order our investigation and plan our management. Coming to history, what all points are important. The age of the patient, it should be noted. Was the course and duration, progression of the disease, any increase following any Valsalva maneuver, is it associated with any visual disturbance, diplopia, any pain, redness, is there any associated neurosensory loss? So why age is important? Because there are specific disease for the specific age groups. Like in children, we can have dermoid, benign lesion like dermoid or hemangioma, and malignancies like rhabdo or gliomas. In middle age, more common are thyroid eye disease like cranial gland mass or NSOI, and in elderly we can have malignancies. So it's important to note the course and duration, because if it's acute presentation, we know we are dealing with any infection, inflammation, or there can be hemorrhagic, acute hemorrhage in case like in lymphangiomas where after the respiratory tract infection we can have a sudden bleed. Or it's a chronic, we can have thyroid eye disease, dermoid, or any tumor. So course of the disease is very important to note, and if whether it's in between within the hours or it's when taking a months or years for proptosis. Progression should be noted whether it's progressive disease, is static or intermittent. Intermittent one are usually seen in cases like lymphangioma or varices. And is it associated with is it associated with pain? Severe pain is usually seen in cases of infection or inflammation or vascular lesion like high flow CCF or malignancies, and dull boring pain can be seen when there is a bone erosion. So all these points are very important and we should ask in history. It is also important to ask for any BRUI, any history of trauma, relevant systemic disease, and note down any past medical, surgical or family history. So coming to examination, it's important to have a thorough systemic and ophthalmic examination. Note down any facial asymmetry. Whenever we are doing the systemic examination, it is, the lymph nodes should be palpable. We should palpate the lymph nodes, and detailed cranial nerve examination should be carried out. And as simple as cutaneous examination, which can be done in OPD. So presence of cafe alert spot indicates that is towards the neurofibromatosis. Coming to ophthalmic examination, it's important to note down the best corrective visual acuity, pupil assessment, both direct and consensual reaction should be noted, and any discrepancy in size requires a thorough evaluation. IOP measurement, especially in restrictive pathology, we know that when we measure the IOP in upcase, there is a rise, like in thyroid eye disease. And interior segment examination includes the examination of conjunctiva. If we see a salmon patch-like lesion, it indicates lymphoma. This lobulated vascular lesion suggests varices. Elevated episcleral vessel indicates there is a raised venous pressure, so you suspect the vascular pathology. Iris should be examined, like lesion like Lisch nodules indicates neurofibromatosis. So all the examination will help us in narrowing down differentials. And detailed fundus examination is required to see any pressure signs, if there is any papilledema, the presence of optociliary shunt vessels indicates meningioma. Oculomotility assessment should be done in all 9 gazes. It helps in noting diagnosing is whether it's restrictive pathology, paralytic, or it's a mechanical motility restriction. So one can do the force reduction test to differentiate between the restrictive and paralytic pathology, and uncover and PVCT can be done for noting down the documentation of the eye alignment and for documenting the diplopia charting and binocular vision. Color vision is done to if there is an abnormality, it indicates the optic nerve compression and also visual field. So all these things, and depending upon what are you dealing with, these are the things you should keep in mind and do in your documentations. Coming to examination of proptosis, it is important to know whether it's unilateral or bilateral. So there are specific diseases which are present bilaterally. So it should be noted whether the displacement is axial or non-axial. And if there is an axial, we know we are dealing with the intraconal lesion like thyroid eye disease or cavernous malformation, schwannoma or gliomas. Non-axial proptosis is basically the eyeball is pushed in the opposite direction of the mass. If it's an upward displacement, we are dealing with the lesion in the inferior space. If it's downward, we know it's a superior mass, and down and out is a medial, supromedial mass, and down and in we have the supralateral mass. So all these points are important to know. The measurement of proptosis should be done in all 3 directions. If it's a subtle, you are not very sure, you can do a Navier method or worm's eye view, which helps in note down the if there is any proptosis. So axial proptosis is measured using we can have Lewis or Hertel being the gold standard. But however, if you don't have anything handy, you can use a simple scale, put it at a lateral orbital rim and measure the distance to the corneal apex. And you will note down, if, you will know that it's a proptosis or not. So for hurtles, it's important certain points to note down the bar reading, remove the parallax so that you have a proper reading. The horizontal displacement can be done by using a scale, put a mark at the root of the nose and measure the distance at the medial limbus. And if there is a vertical dystopia, then you use the two scale methods. So it's important to note down any, you can have a non-specific changes like edema, arrhythmia, which may be indicating a infection, inflammation, or a malignancy. So these all points should be noted down. It's important to put a finger, palpate between the orbital rim and the eyeball, and if you feel any mass, indicates the mass in the anterior orbit, and if you have a mass in the around the orbital margin, palpate it, see the temperature, surface, is it mobile or not, is fixed to the underlying skin, overlying skin or underlying bone, whether it's reducible or compressible. Lesions like hemangioma, schwannoma are compressible. However, if it's non-reducible, it means it's a solid mass behind. And you can perform the Valsalva maneuver whenever you're suspecting a vascular lesion. This is an example of viruses. So it shows the increase in proptosis. Auscultate any pulsation if you feel. It can be a vascular pulsation or transmitted in cases of neurofibroma due to the defect in the sphenoid wing. So all these points are required depending upon what you are dealing with. So remember, whenever you have a patient of proptosis, remember 9 P's, whether the pain, progression, proptosis, palpate, pulsation, see the pupil, PBCT, perception of color vision, and see if there are any periorbital changes. And the 10th one is also important, the past medical or surgical history. So remember, whenever you're taking a patient of proptosis, in history and physical examination, these P's are important. And then narrow down your differential, orders the investigation, lab investigation, and imaging, and then you can go ahead and plan and the management of these patients. Thank you.
Thank you, Dr. Shalu, for building up actually how to approach a case of proptosis. And any questions? Otherwise, I can go to how to manage these patients surgically now. Okay, I think we'll go ahead and we can. So I will not go through in listing these different tumors, because whatever structure is there in the orbit, it can produce a tumor. So it is as simple as that. So no need to learn these. Now the thing that we need to decide is, once we have come to some diagnosis, yes, this is a tentative diagnosis, I want to confirm it and then proceed with my definitive management. So some cases would require incision biopsies, other would require excision, and some even exenteration. So these are the battery of investigations which you need to do before you do any kind of intervention. Now, whenever you have a tumor, you need to see where exactly it is located. It is in the medial compartment, lateral compartment, superior or inferior compartment. It is in which of the surgical spaces, which is the most important part. As Dr. Shalu had already emphasized, if it's in the intraconal compartment, the proptosis is going to be much more. So any mass which is in the intraconal compartment, and again which is located posteriorly, will be the worst or maybe the most difficult to handle. So whenever we talk of compartments, we talk of anterior 1/3, middle 1/3, and the posterior 1/3. The posterior 1/3 approach is, again, it will not be possible to approach it through an anterior orbitotomy. So now let us see what are the different approaches that we follow. These are the classical approaches which have been described. All the tumors which are in the anterior 1/3 of the orbit, they can be easily removed by the anterior orbitotomy. Now if it is in the superior orbit, then you would either use a skin crease approach, or if it is in the posterior orbit, you can even go for a vertical lid split approach. If it is in the inferior orbit, again a skin approach could be a subciliary approach, or it could be a lid crease approach. If it is, the other cosmetically nice approach which nowadays we are using is the swinging eyelid crease incisions, that give a very good approach for the inferior orbital masses. The medial approaches again can be transcaruncular, transconjunctival, and these are the commonest which are being used. Lateral orbital, of course, it has evolved through all these, but most of us nowadays would be using a upper lid crease incision, stellar right incisions. So now let us go through examples. Now this is a case, very typical, old patient, 60-65 years old patient, bilateral involvement. You're not planning any excision, you simply want a diagnosis, so you will go for an incisional biopsy from the most prominent area. Again, an incisional biopsy, rhabdomyosarcoma, a sarcoma, where again an incisional biopsy to confirm, and a definitive management after you have confirmed your disease. Now this is a patient, again this mass is located in the anterior 1/3, it is in the extracorneal compartment, you can see, and this is just to show that whenever you do any kind of excision or debulking, this is a debulking, be aware that you are going to encounter some muscles. So you have seen this is a laterally located mass, the lateral rectus has to be hooked, the mass has to be debulked, and you need to be careful to not to injure the muscle in that particular field. Now the vascular malformations, this is a young child, very tempting, a very anteriorly located mass. You do a Valsalva and the Valsalva is positive, so you think that if it is a Valsalva positive, it's going to be a venous malformation, but on getting a color Doppler, we found that there were arterial waveforms. So be aware that do not jump onto surgical maneuvers without doing a good workup, and this patient would possibly need some kind of arterial coiling or something before you take it for surgery. Another case, these are lymphatic malformation, sudden acute onset malformations are always there. The patient may have a URI or a trauma, and suddenly you find that the patient lands up in the casualty like this. A simple ultrasound, you will see that these are the large cystic spaces, and all you need to do is aspirate this and inject a sclerosing agent. So very easy to treat, only they appear alarming. Now look at this boy, he was about 25 years old, he presented to me with a mass over here. It is quite anterior and it is becoming prominent, appears to be preseptal in location, no proptosis. So this mass can be easily removed. Now remember again, here you have to be careful not to injure your inferior rectus. So the first thing I did was, I just hooked my inferior rectus. You can remove it through a transconjunctival route. I chose to do for a subciliary incision, and you can see this mass, it's sitting quite comfortably. A lid spatula has been used to push up the mass a little so that I get a good exposure, and then very carefully you just keep dissecting all the tissues around it, and you can remove this mass. And this mass was actually a combination of vascular as well as orbital fat that was there, and he did well. Now look at this girl, another young girl about 16-17 years old. Besides having a mass which is present inferiorly and pushing the globe up, there is a lot of proptosis. That means this mass is going somewhere in the intracorneal area. So you can see here, this is the swinging eyelid crease incision. This is the transconjunctival route which has been, I have again hooked the inferior rectus muscle, and you can see this is the conjunctival peritomy. Again very carefully just push up the mass. This is again a vascular mass, and you can see a lot of blood oozing out of the mass, and possibly she must have had multiple earlier small ruptures, because of which there was a formation of lot of adhesions. So very carefully, don't pull out these masses, be very careful in your dissections, but because otherwise you will end up in orbital hemorrhage on table itself. This is another young boy about 25 years old, came with proptosis, and there was also a lateral displacement, and by the time he came to me, already you could see that there was a disc edema. The patient the vision had dropped down to 6/18, and on the scan you can see this is a medially located mass. It is extracorneal in location. It is just pushing, the medial rectus is just being pushed by the mass. So something had to be done urgently about it. I thought I'll go through the skin route. This is the medial rectus that was hooked, but the mass was going so far posteriorly that I could not get a very good view of the mass. So ultimately I had to cut the medial canthal area. So remember that this is the medial canthus. So without injuring the canaliculi, I just cut the medial canthal area. whenever you're removing any of these tumors, cosmesis is one part of it, but it is more important that you have a good surgical exposure and you remove the entire mass in totality. So this mass was removed from the medial. It was a combination of conjunctival and skin approach, and finally I could bring the mass out. So this was the mass. Now the neural tumors. Now this is again a girl about 26 years old. She is a sister in the hospital. She presented with a supraorbital fullness, and on getting a scan done, I saw that there was a mass which was extending right till the orbital apex. It was actually a frontal nerve schwannoma. So now we see that this mass is going right till the apex. Although it is still extracorneal in location, you cannot get a very good approach with any of the procedures except a vertical lid split or a transcranial approach. I gave her both the options. She refused for the transcranial approach, and ultimately I did a vertical split. And this is a little bit of scarring you do get in this kind of approach that we have to explain to the patient. Now this is again a lady somewhere in 30s who presented with a proptosis, and this is a very large intracorneal mass. You can see here there is a variegated appearance, and I'll just show you. This has to be taken out through a lateral orbitotomy, and this is how you need to expose the lateral orbital wall, and this is the periosteum being incised. And after you reach the periosteum is reflected, and after a good bony exposure, you need to make a window of the lateral orbital wall reflection. So the upper end would be this is the frontozygomatic suture, just about 3 to 4 millimeters above, and the lower one would be at the floor of the orbit. So you give this is the electric saw being used, and the bone is reflected at the junction of the greater wing of sphenoid and the zygomatic. So very carefully you need to dissect these masses. Again, remember the lateral rectus has to be saved. So again, whichever compartment you go, you just keep checking what all nerves and structures are coming. So this is the mass, and this is the lacrimal gland which is adhered to it. So again, very gingerly dissect the lacrimal gland away from the tumor, and you can remove the tumor. So this bone doesn't need any screwing and anything. Once you remove the mass, you just push the bone back into place, suture the periosteum properly, and the skin closure is done. Now this is a patient about again in 30s, came to me with a axial proptosis over here, and if you look at the scan, he has a glioma. So glioma, the diagnosis is mostly on the scans, and you don't need to do a biopsy unless if it the image is inconclusive or the tumor behavior is aggressive. So you can directly go for a radiotherapy. Now these lacrimal gland tumors, they appear to be very simple. You can see a very homogeneously, nicely sitting mass over here in the lateral wall, ready to be lateral orbital compartment, very easy to remove. Remember that most of these would be pleomorphic adenomas, very well encapsulated over here. But remember that whenever you are removing these masses, you should not breach the capsule, because if you breach the capsule, there are chances of malignant transformation and recurrences later on. Again, you need to differentiate before you go in for surgery whether it is malignant or it is benign. So malignant cases would have a shorter history. They may have pain, and if you look at the scan, you will have a little bit of bony erosions, and it's an irregular mass. So this patient was an adenocarcinoma, and post removal of these masses, these patients would need radiotherapy. You must counsel the patient. So just a video how to. So again, this is the stellar right incision. You can see the mass sitting right there. Nothing difficult, but the most important part is again very gingerly save the capsule, not to injure it, and remove the mass. So you need 2 or 3 good assistants whenever you are doing orbitotomy. Do not go with one assistant. At least 2 assistants are required for a good exposure, and you should be always ready with cauterization and everything in hand. And this is just how you need to take it out. Sometimes if you need, you can actually chip in the superior orbital margin to get a better exposure. Now, this is a patient of pleomorphic adenoma. I only operated in 2012. I thought it was a very good dissection. You can see the capsule appears to be intact. Unfortunately, this patient had a recurrence. He presented in 2019 again. We did a biopsy, again a pleomorphic adenoma. Then he was again lost to follow-up, and by the time he reappeared, he already had developed malignant transformation. So this is carcinoma ex pleomorphic adenoma. So remember, whenever you have recurrences, these patients need to undergo radiotherapy, and this could have been very well prevented by doing a timely intervention. Another patient referred to me with again lacrimal gland mass, and if you see there was the incision biopsy was done elsewhere, and they found that there were a lot of adhesions, and it was actually a salivary duct carcinoma of the right lacrimal gland. So again, here excision did not have any role. Already the mass had extended into the periorbital in the perilacrimal gland area. So I performed an excision along with the help of my colleagues at Rajiv Gandhi. We did a lymph node dissection and a partial paratoctomy, and then the patient was subjected to radiotherapy. So every patient has to be, dealt separately, and a plan has to be made. Now this patient came with again a superior orbital mass, but when I got a scan done, I saw all the sinuses were full, and on probing further, I found that she had undergone some kind of a nasal surgery. So this was actually a mucocele which had extended from the nose right till the frontal mucocele, which had actually come into the orbit. So this was referred to the ENT department. Now just to recapitulate, if you look at all these masses, this is the boy which I had shown. Anteriorly located mass could be removed through the skin route, through the conjunctival route. This this mass is again inferiorly located mass, but it is going way beyond. So one has to be very careful when dealing with this. This much better to go for a swinging eyelid crease incision, which will give you a better exposure. This mass located anteriorly, you can go through anterior route. This mass again going way back. So although located superiorly, you need a vertical lid split. Here is a mass that would require a lateral orbital. Remember, all masses in the intracorneal area, in the middle third and beyond, will not be approachable through an anterior route. And these masses would require a transcranial approach. Thank you so much.
Thank you, Dr. Ruchi, for very nice videos. And it's very important that you do the proper workup and imaging and plan your incision from where you approach the tumor. So very well nicely shown all the videos that you should plan. It's not necessary that you go for the cosmetic incision. The good exposure is must in all these cases. And if a deeper tissue is there, use of cryo. Cryo is also very handy, and you can use the cryo. Any question from any audience? Dr. Shah, you want to? So now I'd like to invite Dr. Shaleen Shah. He will be speaking on interpretation of imaging and relevance of orbital perfusion.
So, ma'am has given us a very comprehensive view of how to remove the tumors. Now, I'll just brush upon. Sometimes we need to look at the DICOM images ourselves and before planning the surgery. And often the diagnosis given by the radiologist is, we may differ in our clinical diagnosis as compared to the radiological diagnosis. And so at this point of time, we need to have our own DICOM app in our laptops and go ahead and interpret the images. So the first thing is when to look at the CT and when to look at the MRI of orbit. So whenever we have a case of proptosis, screening tool can be a CT scan, because orbit has a lot of fat which provides a contrasting medium, and very well-defined lesions can be easily seen on CT scan. Plus, whenever we are planning an orbitotomy surgery, we need to look at the bony anatomy. Where is the cribriform plate? Where is the anterior cranial fossa? How low is the roof of the orbit? And accordingly, we can plan the creating the bone window for lateral orbitotomy. And hence, CT scan helps there. MRI has its own uses, and we'll come to that eventually. So first, we'll discuss some of the cases where CT scan has a much important role as compared to the MRI. So this is one of the classical cases that we see in our oculoplasty OPD. History of trauma and they present with enophthalmos, limitation of movements, diplopia. And as we can see here in the right orbit, there is a fracture of the floor, and along with that, there is a fracture of the zygomatico-maxillary arch complex. And we can see the inferior rectus muscle, which is at a lower position as compared to the left orbit. So this is one place where we need the CT scans exclusively, and we need it in multiple views. So bony window is extremely essential to know the exact dimensions of the bony defect, and according to that, we'll be planning how big of an implant, medpore or titanium mesh or whatever, has to be arranged for the patient. And such cases, we also need to look at the sagittal cuts, because we need to look at the bony ledge, that is the posterior extent of the fracture where our implant would be resting. In case, like in this case, there is an inadequate bony ledge or there is a fractured bony ledge, then we may have to screw the implant at multiple places anteriorly to keep it in proper position. Here we do have the palatine the orbital process of palatine bone intact, which can be used to support the implant. And we can also see that the inferior rectus muscle, it is sagging, which would suggest a possible entrapment in these cases of the sheath of the inferior rectus muscle. And 3D reconstruction, again very essential, because this is what we are going to see when we open up the patient. So here we have a displaced fragment of the zygomatic arch, and there is a fracture alongside it of the lateral wall and the floor. And hence we need to plan a lateral orbitotomy with a swinging eyelid crease approach to access the floor of the orbit and have adequate exposure of the zygomatic arch as well to fix the tripod fracture as well as the orbital fractures. Next, we have the other common entity, that is dermoids. Now here we can see a left internal angular dermoid, and we can see some changes, bony changes at the base of the dermoid. Comparing it with the right side, the left bone appears hyperostotic. There appears to be some form of cavitations as well. And hence, it's very essential to remove all the cavitations, and sometimes there may be communication of the dermoid across the bone, that is a dumbbell dermoid, and those need to be curated out properly to prevent recurrence. The next commonly seen case is implants. So here CT scan, I would prefer a CT scan over an MRI, because the CT scan would provide us an overview of where the implant is located as compared to the bony anatomy and the fitting. Sometimes the implant may be dislocated from its location. It may not be exactly intraconal, and the prosthesis may thus be decentered. And using imaging can help us guide further interventions for a cosmetic outcome. And finally, as ma'am had shown, lacrimal gland masses. So here, it's very essential to have a CT scan along with MRI in certain cases when it may be engulfing the muscles or the optic nerve or the orbital apex. So using a CT scan is essential because we can determine the posterior extent of our bony window creation. As we can see here in the first image, since the mass is not going into the posterior third of the orbit, a simple lateral orbitotomy with breaking of the bone at the junction of zygomatic and greater wing of sphenoid can help. And the coronal view helps us determine the anterior extent of where the incision should be placed. In certain cases, when it's too far posterior, when it's invading the posterior orbit as well, we may have to chip off the greater wing of sphenoid to access the orbital apex. Next, we have cases of post-traumatic nasolacrimal duct obstructions. Here, imaging in form of CT scan is extremely essential to know the bony anatomy, the displaced fracture fragments, and the hyperostosis that has developed post-trauma. And as we can see here, there is bilateral hyperostosis with bilateral encysted mucoceles. And the bony window is also extremely essential to know the thickness of the bone, exact thickness of the bone, which may not be evident in the plain soft tissue window. And if these patients are to be planned for endonasal approach, a coronal endonasal DCR approach, the coronal scans are essential to know the exact location of the trauma fragments, the relation with the middle turbinate, and the thickness of the bone, whether it can be removed through the bone punch or we may have to use a micro drill for endonasal TCRs. And finally, we have thyroid eye disease. Inactive thyroid eye disease, when they require orbital decompression, again, CT scan is a very essential tool because we need to look at the bulk of the greater wing of sphenoid here, where we see a Mercedes-Benz sign of the zygomatic arch, greater wing of sphenoid, and the lateral wall of the middle cranial fossa, because this is the main part where the deep lateral orbitotomy is done, deep lateral orbital decompression is done. So if there is a bulk here, we can expect good correction after decompression here. And a CT scan is also essential to differentiate a muscle predominant disease from a fat predominant disease, because fat predominant disease would respond well to a fat decompression. And finally, as ma'am had shown a frontal sinus mucocele, we have a similar case. Here the bony window CT scans are essential to rule out erosion of the anterior cranial fossa. If there is an erosion, it would be a combined approach between a neurosurgeon, ENT, and an oculoplasty surgeon, as we can see in this case. And this is one of the rare cases where we had an adenocarcinoma of the nasolacrimal duct who had undergone a previous external DCR which had failed soon. And here we can see the exact extent and the bony erosions, the destruction of the middle and the inferior turbinates. And these are usually not very appreciable on the MRIs, and hence a CT scan would be much preferred in these cases. Now, when to use contrast and when not to use a contrast. So most of these cases till I have shown till now were non-contrast scans, and they provided us a very good method to determine the surgical plan. Now, these are some cases where lacrimal gland masses extending into the posterior orbit, and we can see a brilliant contrast enhancement in these masses. So these are usually malignant masses because a pleomorphic adenoma usually would not enhance so much, and this patient turned out to be an adenoid cystic carcinoma of the lacrimal gland. And the other variants are the orbital soft tissue tumors, which is the rhabdomyosarcoma, and here post-contrast we can see some areas of non-enhancement which suggest necrosis inside the rhabdomyosarcoma, and the non-contrast scan shows a variegated appearance. Finally, moving on to the MRIs of the orbit. So we have T1 and T2 weighted images. The T1 weighted images are basically to look at your anatomy. So here we can see the left orbit, beautiful muscles, a beautifully delineated sclera, whereas the T2 is used to look at the pathologies. So we can see some mass in the lateral orbit abutting the lateral rectus muscle. Now further we go ahead with the STIR imaging, which is a fat suppression image, and we can see the mass remains unchanged with fat suppression. And the other we have is FLARE imaging, which is fluid suppression, and we see the mass disappears on FLARE. So this is predominantly a fluid-filled mass located inside the orbit, and it turned out to be a ciliary body cyst. Again, we have T1 and T2 weighted images, and T1 and T1 contrast weighted images. I'll skip this. So here we have a very characteristic appearance. On T1 we have a hyper intense mass over with a hypo intense vitreous, and on T2 we have a hypo intense mass over a hyper intense vitreous. So this is known as the yin yang sign, and it has some specificity for melanoma lesions. However, some leiomyoma lesions of the orbit also show this appearance. And here we see a huge ill-defined mass on the T1 image, not very well seen on the T2 image. But as we go for the diffusion weighted image, we see a hyper intense mass. So now diffusion weighted imaging is another important concept in MRI. This is useful when we want to look at the cellularity of the mass and compare it with the water content. So as we know, we see the vitreous as a hyper intense thing, so that is a water rich area, and we see another diffusion weighted hyper intense mass in the anterior orbit. Now, how to differentiate between a fully water filled mass versus a fully cellular mass? So there we have the absolute diffusion coefficient, ADC, which compares how much change in the MRI signal is noted over 100 milliseconds. So as the same mass, when we see on ADC map, we see vitreous to be a hyperintense mass, so it's filled with moving water molecules. But the hyperintense mass now goes hypointense. So here there are not many moving molecules, so it is supposed to be a cellular mass. So whenever we have a low ADC mass, it suggests a definite hypercellular lesion. In this case, it turned out to be an orbital lymphoma. But even benign lymphoid hyperplasia or a low-grade orbital lymphoma like mantle zone lymphoma could present in this way. And such findings warrant an immediate orbital biopsy, incision biopsy. And now here, this is the last MRI I have. We have a T1 image which shows a diffuse mass circumscribing the globe on the right side, and on the left side we have some mass in the lacrimal region. And again on the ADC we see, on the diffusion weighted imaging, we see enhancement in the inferior right orbit, and on ADC we have some hypointense areas in the inferior orbit. Again, this turned out to be a lymphoma, bilateral orbital lymphoma. Now we have just brushing across orbital ultrasound. So as ma'am had already shown a similar case, orbital ultrasound is very good for venolymphatic malformations. Here we see multicystic lobulated lesions with fluid levels. So this was a hemorrhage inside the venous malformation, venolymphatic malformation. And other important places for intraocular tumors like uveal melanoma, where we see a very distinct appearance. Sometimes it may break through the retina and we can see the mushroom-like appearance of the melanomas. Now moving on to the perfusion studies of the orbit. Here we have orbital color Doppler. So here we can analyze the central retinal artery or the ophthalmic artery mainly, and they are localized with the help of the radiologist. So this case again, ma'am has already shared, it turned out to be an arterial malformation, and the Doppler showed a definite arterial waveform. Now we have another place where orbital perfusion studies are gaining importance, and that is thyroid eye disease, especially moderate to severe thyroid eye disease who do have some form of vision loss, progressive vision loss. So here orbital perfusion studies are extremely essential. We can see the CRA, it has very little flow and absent flow during the diastole phase of the cardiac cycle, and the ophthalmic artery again has very poor flow. These suggest orbital ischemia in addition to the thyroid eye disease, which may be leading to the visual loss. And this is the patient who underwent decompression surgery, and we can see the improvement in the orbital blood flow in the central retinal artery before and after surgery, and in the ophthalmic artery before and after surgery. So this is a new modality of investigation for thyroid eye disease where orbital perfusion can help us guide our interventions. And some surrogate markers when orbital color Doppler is not available would be OCTA macula and OCTA disc, to have an indirect evaluation of what is the blood flow status for the orbit and the globe. Thank you.
Thank you, Shalin, for the wonderful and extensive talk. I think first I'll finish my talk before, and then whatever questions anybody can ask, we can take at the end. I think that we have just 10 minutes left now. So I would be talking about, the thyroid eye disease is the commonest orbital pathology I think we all encounter. So what we really need to do, I'll just take up some cases and share the practical way to approach them. So just to brush up, whenever a patient comes, one thing is we need to know whether it's a mild, a moderate or a severe thyroid eye disease, whether the patient is in active phase or he is in inactive phase, what is the duration of the thyroid disease, and what is the duration of the thyroid eye disease and the duration of the thyroid systemic disorder. The duration of the thyroid eye disease is important because normally what is said that initially there will be an increase in the phase, then there will be a plateau and it will then wean off. But not all patients are going to behave like that. Remember, you may have patients where you treat, they come back again with a recurrence. Then whether the patient is euthyroid, hypothyroid or hyperthyroid, never aim at changing a hyper into hypothyroid. You maintain a euthyroid levels. And Many of your patients would be euthyroid at presentation, and just because thyroid levels are normal, that does not mean it is not a thyroid eye disease. Smoking is the most important modifiable risk factor. If the patient continues to smoke along with your treatment, the patient will never recover and he'll come back again with recurrences. So just to the important factors that we have to differentiate between mild and moderate to severe, because in the mild you just have to observe, give lubricants, give selenium, but when it is moderate to severe or side threatening, then you have to do something actively. Now how do you classify this? The UGOGO classification. And lid retraction more than or equal to 2 millimeter, or exophthalmos more than or equal to 3 millimeter above the normal for a race, constant or inconstant diplopia. So that is how you differentiate. And side threatening, of course, would be where there's a corneal breakdown or the optic nerve is involved. Now there are different scoring systems, and CAS is the most easiest to remember. And just remember that when the patient presents we cannot judge the proptosis. So the patient has, when we are talking about the first presentation, it is just the 7-point system. When the patient presents subsequently, let's say about 3 months later, then you talk about the 10-point scoring system, whether the proptosis is increasing or not. Simply presence of proptosis does not mean that the patient has activity. The activity has to be just if the proptosis is increasing in the subsequent visits. Now, general measures I've already discussed. The first and the foremost is treat the thyroid dysfunction. You keep pumping the steroids and doing everything. If your thyroid dysfunction is not controlled, it will not work. Always identify the high risk factors, and if TSH receptor antibodies or there is a unstable hypothyroidism, take help of your endocrinologist colleague. Treat the dry eye. This mild TED, again, very easy to handle. Just lubricants, keep a watch. Sodium selenite 200 micrograms daily for 6 months is prescribed. Now the moderate to severe active TED, this is the important part. First you have to identify if the CAS scoring is 3 and more in the first visit, then it comes into a active phase. If it is moderate to severe and the patient is bothered by the day-to-day social activities, then you need to do something. So earlier on we all used to give a lot of oral steroids, but I think most of us have shifted to IVMP now. And this is the standard dose where we give 500 milligram of IVMP weekly for 6 weeks, which is decreased to 250 milligram weekly for the next 6 weeks. And the recommendation is that it should be combined with mycophenolate mofetil 500 milligram BD for 6 weeks in the first phase, and for 18 weeks mycophenolate continues a little longer, and together they are supposed to give a better treatment response rather than IVMP alone. Suppose we do not get a response in the first week, then we go in for second line therapy. That is, you increase the dose of IVMP, you may combine orbital radiotherapy with steroids, or you may use teprotumab, rituximab and tocilizumab. Teprotumab came in a big way, and especially in US there were a lot of studies, and it was once upon a time thought that maybe the surgical decompression will be replaced by medical decompression, but again the problems related to teprotumab and the expenses, it is still not become a very popular drug, and it continues to be a second line treatment. Now very important is, when you are giving an IVMP, please do a baseline investigations. The patient should not have any chronic any active infection at that point of time. You should also check for viral the liver function test. There should be no history of any recent viral hepatitis. Any severe cardiovascular morbidity, uncontrolled hypertension, do not prescribe IVMP in your ophthalmic center standalone if you have any of these problems. The diabetes, many of these patients would have diabetes, so you have to ensure that you either switch the patient to insulin, or you increase the dose of oral hypoglycemics, and never to increase the cumulative dose to more than 8 gram, because the patient would have problems after that. Now let us see a few examples. This is a patient who came, a 48-year-old lady. She had hypothyroidism for 3 years. The left eye had a resting orbital pain, and there was inconstant diplopia. She was very unhappy. So she was a case of moderate to severe active TED, and she was given a course of IVMP with mycophenolate, and she was very comfortable after the treatment. But again, a word of caution, she may be happy today, but you need to keep these patients under follow-up, because these patients may again have recurrences, and you have to monitor their intraocular pressures, and you have to monitor their vision on every visit. Now this is a patient where you can see on the top side, you already see there is a proptosis, there is lag of thalamus, there is a corneal breakdown. Here there is no time to waste, you have to act immediately. This patient was also diabetic, and the patient, her diabetes treatment had to be stepped up. She was given a higher dose of IVMP. Remember, there we were given 500 milligram. Here we have started to a 1 gram dose of methylprednisolone. Daily we gave it on 3 days, and then after that we switched her to oral steroids. And remember that if you have no response within a week or so, you may have to sometimes do a urgent orbital decompression in these cases. Another patient, again a sight-threatening thyroid eye disease. The patient actually recovered well after an IVMP, but continued to smoke. So again, after a few months, he was back in the casualty with a similar picture. So remember, you have to tell these patients that they have to quit smoking, or these things will never resolve. Now this is a patient 35. This is a patient who was referred to me for correction of upper eyelid retraction. So she had a stable thyroid profile for the past 3 months. She has proptosis definitely, but she was very particular that I want to get rid of this, So I thought that right now this is not the correct time to go for any definitive surgical procedure. So what can you do if you don't want to go for a definitive surgical procedure? You can go for a medical treatment, something like a Botox injection. Otherwise, for lid retraction, we do graded blepharotomies, levator recession, levator myotomy. Levator recession may be combined with spacers. So depending on how much the retraction is, if it is just 2 millimeter, let's say, you just simply do a blepharotomy, it will be fine. If it is, let's say, 3 to 4 millimeter, you may go in for a levator recession. It may have to be combined with levator myotomy. If it is 6 millimeter, 7 millimeter, then this will not work. So you may have to put in a spacer along with it. So this is where you inject the botulinum toxin. It is a very easy procedure. Just anesthetize and evert the lid, and it is at the junction of this 1/3 and this 1/3 subconjunctival 3 millimeter above the superior tarsal border. And now the dose. The dose, again, different people are using different doses. I usually would use a 5 international unit at one side. Give 2 injections, one at this side, one at, so that would be 10 international units. Wait for a month. If adequate response is there, then it is fine. If not, you can increase, give another shot. But sometimes some people usually go directly to 7.5 units also. Now, suppose you have a large retraction, you can use spacer. So this is just to show how this is the usual levator muscle. This is being disinserted from the insertion, and then it is separated from the orbicularis. So this is in spacers you can use buccal mucosal grafts. I have used these silicone bands which are lying in the OT always, the retina people. You can just borrow one band, and you can see the width. It is about 2.5 millimeter, and you can just suture it to the tarsal surface, and depending on how much retraction you want to correct. So you can actually, because normally the levator is inserting about 3 to 4 millimeter on the anterior surface of tarsus. So you can just you shift your insertion a little more posteriorly if you want a better correction, and this corrects about 6 to 7 millimeter of retraction easily. Now this is another patient, somebody had done a retraction surgery outside and was referred to me for ptosis correction. So remember that sometimes you may do your corrections, and this patient was, we got the hall late. So what I had to do is go back and actually put back the levator in position, and this is how he looked on the post-op table. So now a couple of examples, like this is a patient where this patient had actually more proptosis, if you see carefully, is in the left eye and less in the right eye, but actually his vision was already compromised in the right eye. So remember that just the amount of proptosis does not decide that the patient which eye is more severely affected. So you must do a complete examination, as Charlene had showed you. You must calculate the Barrett's index, and anything more than 50%, there is a chance. You can see here the muscles are so thickened and crowded. So this is a muscle predominant thyroid orbitopathy, and here there are chances of compression of the optic nerve in the center. So these are the patients where you must give a early dose of medical decompression, that is IVMP is required, and you should not delay. Now I'll just skip these videos, and this is just to show he already had actually this nerve fiber layer loss in both the eyes. It had already started in both the eyes. So and he had also developed some field effects. So you must identify your cases and then take the treatment. If you look at this patient, on the other hand, he has Barrett's index is not that bad. That means it's less than 50%. So here the rush is a little less. So looking at the scans, looking at the crowding at the apex of the muscle, you can give a fair idea as to which patient would require a early treatment. So this is post-treatment IVMP. Now Shalin had already shown that it was actually his thesis that we had done, and this is just to show how to do the decompression. It's a very easy procedure. Anybody doing an orbital surgery can do it. So this is the lateral orbital wall. Remember, the lateral canthus tendon is cut, and after doing a little bit of this is the burr, the cutting burr which I had used, and this is the fat. Very gingerly this fat has to be excised very carefully. See how slowly I am going, and this is the bone. This is the actually lateral wall, and it is the greater wing of sphenoid where you have it is a thick bone, that trigone sign which he was showing, where you have lot of space to actually chip off the pieces on the surface and let the fat expand over there. And you can take down you can combine it with the inferior wall decompression till the infraorbital nerves and vessels you see, so that you should not injure the infraorbital nerve, otherwise you get a hypoesthesia. So this is a very easy procedure, and it gives a very good not only cosmetic result, but we have shown in a study that we could these are all actually color Doppler, there's no time, we could increase the perfusion of the orbit after doing a decompression. A last word about the squint correction. Remember, the squint correction is not to treat the movements, it is just to treat the diplopia in the primary and mostly in the down gaze. So all systemic disease should be in remission, and the patient should have a stable ocular deviation for at least 6 months before you start planning any surgery. And remember, there are these muscles, they are fibrous, so you don't go in for resections, you go in for weakening procedures or recessions, and you could combine them with adjustable sutures. So you can, before going in for surgery, go for a binocular single vision field, and after doing a surgery you can just see how much the patient has got rid of the diplopia. And just a take home message, identify your moderate to severe cases onwards, keep a close watch. The muscle predominant cases are the ones which are likely to have a visual compromise faster. Identify these cases, check for the Barrett's index, that is the muscle thickness versus whatever space you have in the orbit. Always check the pressures, because not only the muscles are pressing, there is an increase in the episcleral venous pressure that will cause an increase in the IOP. You must treat the IOP as well. So vision loss could be because of the direct compression of the optic nerve, the increase in the IOP, and decrease in the perfusion. So these are the things you have to address. A timely medical and surgical decompression has to be done, and inactive rehabilitative disease should be done only when the patient has gone into a remission. And if you have to do all the surgeries, the sequences, first the decompression, then the muscle correction, and finally the lid surgery. Thank you so much. Any comments you want to discuss with any questions? Any questions, we'd be happy to take. No queries? Shalin, you want to discuss something? Shalin?
Dr. Ruchi has clearly laid down all the guidelines and which patient, how we have to manage, and it's very important that we follow the sequence, the orbit, then the muscle and the eyelids. And yes, in some cases do come for the lid retraction only. And do you have any experience of triamcinolone instead of Botox in you?
That's not my first choice. Tricot, actually not for lid, I'm not using it for lid retraction. I only use it sometimes, there would be patients where you cannot give systemic steroids. There would be some kind of a contrast. Then peribulbar tricot we have used and we have shown. Actually, there was a thesis at our center. We had good results, but personally, they're very unpredictable. And in fact, fillers and these Botox is better than giving tricot for retractions.
One comment for lid retraction patients. I recently had a patient, 10 years inactive disease and mild lid retraction. We just started her on selenium 200 milligrams, and within a month, her appearance, I mean, she was very happy with her appearance because the lid retraction had resolved and the lateral flare had also resolved to some extent. So maybe that's one of the underrated therapies which have come into the guidelines very recently, but it does give very good results. So just starting selenium 200 milligrams could be a very good option before we go ahead with more invasive procedures. Maybe a trial for a month can be done.
Yeah, actually, Ugogo has given it, prescribed it for mild, but you can also use it for moderate to severe thyroid eye disease. So, Shalu? So I think since there are no questions, we can just close this session. Thank you so much for being with us. I know Orbit doesn't sound very exciting to everyone, but yeah, we had a good time. Thank you so much.